Hello, everybody. It's Dr. James Wright. I'm a staff doctor here at Georgia Chiropractic Neurology Center, and today I wanted to present a talk on dystonia. So let's jump right into it. So first off, the question would be, well, what is dystonia? Dystonia literally means stone-like. So it's a neurological condition that can have a couple different attributes, such as wrenching and twisting of the neck or arm or another body part, either without motion, without cause. So it just happens automatically without, let's say, your own control, or it can be almost an extreme stiffness that you can't necessarily move. So what we're going to be discussing in today's topic are the types of dystonias, the potential causes of dystonia, the traditional treatment, as well as the neurological treatments we offer here at Georgia Chiropractic Neurology Center. So to cover a few, first you have what's called focal dystonia. So a focal dystonia, when I hear focal, I really think of local. It's a one specific body part. So let's say your hand or your neck specifically. So it would only be to that one specific spot. So like if your hand would wrench up and it's automatic, or it would stay wrenched up, you could call that a focal dystonia. Next, you have a segmental dystonia. So that would be two or more adjacent body parts. So let's say it'd be my hand and my shoulder on the same side. So as long as it's on the same side, that would be a segmental dystonia. So it's the segment of this general region. Then you have the multifocal dystonia. So that would be essentially if I had my right arm and then my left leg. So it's opposite body. So it's two segments or more, but different sides. And then you have the hemidystonia, which would be one side of the body. So that could be all the way from your neck to your arm to your leg, all on one side. And lastly, you have generalized dystonia. And generalized, it generally affects most part of the body. And it's typically adjacent to the trunk. So you would say you would have a dystonic or a stiffness or an uncontrollable tightening or urge of movement that you couldn't stop or would have a hard time stopping in the general vicinity of your belly or your trunk, and it would extend to your arms or your hands, and it didn't matter where. So that's to cover kind of the different types of them. So I'm going to stick with cervical dystonia for this talk. It's kind of the most frequent that we see in the office, and it tends to be a more, let's say, popular one to want to try to treat. So cervical dystonia is also called spasmodic torticollis. Torticollis is more of a used term for a lot of chiropractic offices, and torticollis essentially means wrenching or twisting of the neck. As you can see in the visuals we have here, there are different kinds. So you have a rotational-based one, you have a flexion-based, and then you can also get ones that protrude and extrude. So really any motion of the neck can have a dystonic or automated movement that you typically can't control. So here's an image. This is a general image of a patient that has a cervical dystonia. And something that you may notice is the very tightness of her neck and the wrenching kind of over. So as I can kind of get here and I can really flex and move that tightening of the jaw and the tightening of these muscles on this side will be a presentation of a cervical dystonia. And that could be one that either you can relax and then it comes back almost randomly or due to some particular thing, or it could be a constant stuckness of that area. So as I was saying before, it's an involuntary movement or automatic or uncontrollable movement. Can or cannot be triggered, may or may not be. You can have neck and shoulder pain typically, which makes sense because your neck is going to attach to your shoulder. I mean, if I raise this, it's going to affect it because these tend to go together. And then the turning and twisting, that will affect shoulder motions because of these muscles you have here called your scalenes. They attach to the bones that are attached to your shoulder. You can have muscle stiffness and tightness. That's a pretty classic finding on dystonia, which can cause pain and discomfort in that general region because it's like the muscles never get a break. And then head tremor. Head tremor is a common thing most people will see, and it's essentially is you can see things like this because it's like I'm trying to move this way and it's trying to move that way, and there's this control back and forth, and it causes this little shake because the muscles are having a little bit of a tug of war go on. So now, traditional treatments. So the traditional treatments are more on the medical model that have been around for quite a long time now. First off, dystonia is typically considered idiopathic. Now, what idiopathic means in, let's say, layman terms, basically means we don't know. So when you see something that says idiopathic, it just means we're not sure why it happens. We just know that it does. So unfortunately, there's not a known cause. Now, the most common treatment is botulinum injection, or Botox is the common term for it, which is more of a management-based thing for the most part. And you have to go back, I think, every 2 to 3 months to get a certain amount. Next would be dopamine drugs. Dopamine drugs hit a part of your brain, or hypothetically hits a part of your brain that controls movement initiation. So they use that as a potential treatment. Muscle relaxants. I mean, the idea there is that your muscles are constantly moving, so they try to hit the chemical regions that cause muscle activity. And then trying to do that, it tries to relax it. Some people have success, some don't. And then there's also sensory tricks. So a sensory trick could be, say, if your head is constantly turning to the left and it's uncontrollable, it's involuntary, well, one of the classic ones would be you put a coat hanger on your head and it tightens it. And when it does that, that pressure will take this and you can just stay here and be fine. Well, the problem with this sensory trick, unfortunately, is that it has an expiration date. They tend to wear out pretty quick. It works very wonderfully for a little while and then it just stops working, which is an unfortunate thing of it. Now, there's a brain-derived reasoning from all of this. So when you think of any muscle activity or motion, it really has to come from your brain. There's areas in your brain like it called your premotor cortex. So before you make a motor movement or a muscle movement, you have to think about it. Then there's a motor cortex. So it's the actual causation of the movement. And there's other ones that we'll talk more about, such as this thing called the basal ganglia. So that is a set of tiny brain structures that have been very well studied for literally initiating movement. So when I go to do this, that's my basal ganglia saying, hey, I want you to move. And then in order for it to be a nice smooth movement back and forth like this, my cerebellum has to activate. And the cerebellum deals with coordination, and it deals with tonicity of the muscle. If it's loose, if it's tight, which is kind of plays into that rigidity and that tightness and that muscle stiffness. And then lastly, you have your thalamus. And the thalamus works like a relay center. It's like, hey, boss, they said do this, so I need you to do it. And it's almost like, hey, it's that friend that stays in the middle that's telling you everything that's going on. When, it's kind of fun. So next, let's talk about some of the treatments we do here at Georgia Chiropractic Neurology Center. So we do functional neurology. Functional neurology, to break it down, means to physically see things that are going on. One of the tests we might do is have your arms out, and then we might turn it back and forth. Now, what we're seeing is how smooth it'll go from here to here, and then with speed, right? So if you go do this and all of a sudden you start to it starts to shake and you're incapable, that's a sign that there's a functional problem there, and that tells us certain brain areas that are more likely to be correlated there. And then there are particular treatments we can do to go in and exercise them, that is to say, improve them potentially. So some of the things we're going to talk about, and I'll explain these as we go, is gaze stability exercise, pursuits, saccades, and then cerebellar movements. So those words mean very little right now. So let's start with pursuits. So a pursuit is a common treatment you'll see here at Georgia Chiropractic Neurology Center. What it is essentially we will use our thumbs, or really any kind of target, and you will lock your eyes on that target. Let's say it's my thumb. And then when I move it left to right or up to down, or really any directional that we choose, it's going to activate certain parts of your brain. It's going to use the muscles of your eyes, which correlate to segments of your brain, particularly the brainstem and then certain brain areas. For instance, a pursuit is highly likely to activate a lobe called your parietal lobe. Now, your parietal lobe is an area of your brain that helps with regional discovery. So that is to say, like, I know where my arm is. I know that it's on my left side of my body. I know that my hand is right here in front of my face. If my parietal lobe wasn't working very well, I would have no idea that's where that is. If you were to say, hey, can you touch your left arm? And I'd be like, yeah, it's right here. It's way over there. And I may believe that. I would have no idea. It's almost like a grid. You know, if you've ever seen a computer grid or a piece of paper, it's like knowing the location, which seems a little goofy, but realistically, that system's in play all the time. Now, you need that system to know where things are in order to move them properly. So if I go to move my thumb down and I think for whatever reason it's already halfway down, when I move it, I might put more pressure than I should. So when I am here and I put more pressure, it's going to stiffen about halfway. So that could be this like almost a cause of rigidity. The next structure it does is called the pontine structure. That's an area of your brainstem that's very important, say for breathing. It's very important for connections to your cerebellum for muscle coordination. It's very important for eye movements in particular. And the eye movements are important in particular because they have a strong control over your neck movement itself. So this is we call it a smooth eye movement, and it can allow for inhibition of the neck. And inhibition is to say you physically stop it. So next we have saccades. So a saccade is essentially if you decide to look at one area and then to the next. It's a very fast movement. It's almost like a jump. So I look to my left and I look to my right. So it's an instant. It's not like I have to travel it across. It's boom, boom. That's a saccade. Now that's highly regulated by an area called your frontal lobe. The frontal lobe is often considered the CEO, the functional boss of the brain and the body. So when you decide you want to do something, you got to go through the frontal lobe. That's essentially, most people think that's where your personality is. That's where your main cognition centers are. It's where I decide I want to do it. That's what I want to do. I want to move my hand forward. I want to do this. That's typically where it goes. And the frontal lobe activates those quick eye movements. So that's a therapy we'll use, such as if I were to have both thumbs up, and when I wiggle one, I want you to look at it. Now, your ability to do that correctly or not can tell us functional things, and we would exercise that. And then it's also a midbrain structure, which again is in the brainstem, except this time it's on the top of the brainstem. And being on top of the brainstem is really important because it basically has an inhibitory action or a blocking action for the rest of the brainstem, which is going to be really, really good for the rest of the system. Okay, so, and like I said, that's a fast eye movement. It's got target prediction and neck movement. So what that means is if I look to my left, for instance, and it's a quick boom, there's my left, there's a tendency to move my neck, which is a natural response. But if I don't have good blocking of that particular area when I look to the left, then I'm just going to move it. And then there are times when you look to the left with no intention of moving your neck moves automatically, which can be the case in dystonia. So if I look to the left, maybe it could do this, and it could be a reaction because that's a natural movement, but it's a little too sensitive or a little too close to threshold, and then it turns your neck. So those are things that we would notice, and we would see if it's a good treatment or not a good treatment and get it to stabilize and regulate. Okay, so next we have gaze stability. So this is somewhat similar to a pursuit in the sense that you're locking on a target. However, the difference would be when I'm looking at something, I'm using just my eyes to look at it, and I'm controlling it just by my eyes. A gaze stability exercise, as you can see Dr. Ho's doing, is essentially the doctor has her hands on your head and you're staring at a target in front of you, and we're rotating your head back and forth, up and down, whichever direction. That activates a reflexive activation in your brain. That's different activations than if you choose to do something. Because if you look at something, unless a system is just not working well at all, you're going to be able to turn your head and keep your eyes on a target. And it's not like you're necessarily controlling it. It's automatic. It's when I look at it and I turn, my eyes are going to move that direction. So this activates what's called the vestibular ocular reflex. So that means my balance system with my eyes have to coordinate together. And when they coordinate together, then that's working properly. And this is a system we tend to use in the clinic. Now, there are a lot of connections, kind of as I mentioned before, to cerebellum and these eye movements. And when you think cerebellum, you think tonicity. You think if it's tight or if it's loose, and then you see, is it going to go here the way I want, or is it going to go miss? So it kind of helps coordinate things, and that's what you want. When you have a smooth coordination system, it doesn't necessarily allow for it to go off track. When something goes, like if you think of a train off track, it's gonna be rough. Well, really, I think probably more like a Jeep going off trail or something, I guess would be better. It'd be rough riding, it'd be unstable, it'd be bouncy, and it's kind of hard. The wheel might take at some point. So the cerebellum is really good for keeping it on track. Okay, so now we have complex movements. I've said a lot about the cerebellum. I'm a fan of it. Cerebellar activity tends to be anything that is complex. Now, what is a complex movement? Well, as you can see in the picture here, it's essentially one of the ones we do is we'll have your arm out and we'll move it in these various angles. Now, going through these various angles adds a lot of things into the system. And not only does it affect these brake and gas of motion and braking gas of like how tight one side should be versus the other, it also does these different angles. And going through the different angles allows for your brain to interpret it similar to what I was talking about with the parietal lobe. It has to know where it is at all points. Well, it's also adding in this coordination of it with that. So you're kind of double dipping with systems here, which is really good. So that's a cerebellar activity. Now, it also is a basal ganglia activity because you're initiating movement. So if I go down and then up, I have to make the decision to go down. I initiate it that way. And now to go up, I have to initiate it. So I would choose different angulations. So one of the things that kind of comes around is a bit of a tremor. So let's say it shakes. Well, if I go to move it and the shaking stops, that means that the cerebellum has now taken a little bit more control and it's blocked the tremor a little bit. Whereas if I am fine and then as soon as I move, it shakes, then I have to decide which one's more driving, the basal ganglia from the initiation of movement or the cerebellum. Now, these things are used in practice as exercises, and we're trained clinically to understand whether it is more of a beneficial or non-beneficial exercise for you. And on to the next thing. So why the brain matters. Well, there are over 20,000 publications on PubMed alone, and these are all about why the brain is doing the thing. So there's numerous amount of publications on movement in the basal ganglia, movement in the cerebellum, and all that really is to say is when you kind of study it and you put these pieces together and connect the dots, you start to realize that you can exercise these areas and you can benefit an individual that has these particular conditions. And we have pretty good results with this stuff. And these are things you can look at if you ever wanted. You can just type in these things and it'll pull it up. So these exercises have been shown to have validity in reestablishing brain connections and a thing we call neuroplasticity. That basically means almost like keeping a permanence. If things are done correctly, then the correction should stay, is essentially what it is. Now, that's not always the case. Things sometimes are more along the manageable side because these are difficult. And it's like I said before, I mean, whether it's us or the full, the medical community in general, these conditions are more considered idiopathic. We don't really know why they occur, but we do the best that we can. And like I said, I think we get pretty good results. And last but not least, I wanted to talk about our staff. So this is the staff at Georgia Chiropractic Neurology Center. You have Dr. Hose here on the left. You have Dr. Jimenez, Dr. Bouth, Dr. Owens, Dr. Patterson, myself, and then our leader, Dr. Mark Ellis. And Dr. Mark Ellis is trained with Dr. Frederick Carrick, who is world-renowned as a functional neurologist clinician. He was one of his, in my opinion, best students, I think. And so that is to say that we're led pretty well here in the clinic. So anyways, Thank you for listening to my talk. You guys can schedule for a complimentary consultation today. The information is here, and we also have a barcode for you to scan for your convenience. Hope you guys have a wonderful day.